What about non-primary or metastatic tumors to the testis? Lymphoma and leukemia are some of the most common to occur. They tend to affect the testes bilaterally, and they are often somewhat mothy. The testes become enlarged, they become heterogeneous. Increased flow, again, is not specific. Metastatic disease of other types of tumors, we see lung, prostate, GI, renal, melanoma. Not as common as lymphoma and leukemia, and are seen as end-stage manifestations of metastatic disease. These people often will have widespread metastatic disease. Here is somebody with chronic lymphocytic leukemia, bilaterally enlarged testes with a lot of increased blood flow symmetrically. These testes are not as hard and firm as people who have primary tumors, and it would be unusual to have somebody present with bilateral primary testicular tumors. And of course, the history is important, as we can see in somebody known to have a lymphoma or a leukemia. Just one other point I want to make is that sometimes when these people are treated for their lymphomas or leukemias, there is a type of barrier that may prevent that chemotherapy from treating the testicular component of that disease. So it would be important to watch if you see some abnormality in somebody's testes after they've had chemotherapy, to recognize that they may have not achieved the goal of good therapy with respect to the scrotum. Now, what about this controversial issue of microlithiasis? The literature would suggest that there are many entities that are associated with microlithiasis. The literature also suggests there's a predisposition to germ cell tumors in people who have this, although that incidence is controversial. A very nice article I'll reference here was published to bring our attention to the association of microlithiasis to intratubular germ cell neoplasia. Now, it's very unfortunate that we don't have a marker for who has associated intratubular germ cell neoplasia when somebody has microlithiasis. The best we have are some references in the literature to suggest when you have microlithiasis, you may have a relevant increase, maybe up to 22 times. Notice that when we're looking and we see microliths, there's an elevated, when we're thinking about microlithiasis, we would like to suggest you use a high-frequency transducer and have more than a single or perhaps even more than 5 microliths per image. This is a widely quoted article that came from Mallinckrodt in St. Louis, suggesting that we should consider microlithiasis as limited when there are few microliths, the association of neoplasm, perhaps 2%, more than 5 microliths per image, increasing the likelihood of having associated tumors. But I will stress that it's important to have good technique if you're going to see microlithiasis. Megahertz matters. Low megahertz, poorer resolution, you won't see as much microlithiasis. The equipment matters. Again, lower frequency, maybe a 7 megahertz to a 15 megahertz. Older equipment, newer equipment, you will see more microlithiasis. So megahertz and equipment matters here. Here we have obviously classic microlithiasis, huge number, a few microliths in a patient as we see in this scan. But what shall we conclude? Well, here we have classic microlithiasis with an associated germ cell neoplasm. Here, however, we have only a few microliths, and this patient also has a seminoma. How do I counsel a patient? Well, if I see a large number of microliths, I'm going to alert that patient, particularly to do self-examination. What if I only see a few microliths? The literature is still fuzzy on that with regard to this. There is clearly not, the bottom line is we don't really know. If I could know if this patient had intratubular germ cell neoplasia, obviously I would be concerned, but I can't, there's no marker for that. So in general, we tend to ignore limited microlithiasis, and I think we definitely should follow people who have this extensive degree of microlithiasis, because these are clearly people at a higher risk. Let's now move away from the testis and talk about other entities in the neighborhood, in the scrotum, beginning with epididymitis, which is a retrograde spread of infection from the urethra, prostate, or bladder. It's somewhat analogous to pelvic inflammatory disease, which is also a retrograde infection through the cervix, uterus, into the tubes, and ultimately may affect the ovaries in a female. If it's retrograde, it wouldn't surprise you to suggest that the tail of the epididymis is initially involved, as we see on Dr. Netter's diagram, and then it can progress to involve the head. The testis can be involved either by flow of the infection spreading from the head into the mediastinum and then into the testis, or by contiguous spread of infection, as we see here on Dr. Netter's diagram, with a perhaps 20% association of testicular involvement with people who have epididymitis. So it shouldn't surprise you when somebody has acute epididymitis that the tail of the epididymis, which is typically inconspicuous, as I mentioned at the beginning of this talk, becomes much more conspicuous and may even be larger in comparison to the head of the epididymis. Hydrocele are often seen, simple or complex. Here's a case where there's bright echogenic foci, some of which have shadowing. The clip will show you these perhaps to a better degree. These were actually little air bubbles in this unfortunate man who had very, very severe epididymal orchitis. I'm going to come back to this case in a few minutes. Abscesses, hard to know sometimes. Again, I bring your attention to the enlarged tail more than the body and more than the head. But by turning color on and seeing a void of flow, you might bring up the possibility that this patient is developing a phlegmon, as he was, and subsequently developed an abscess. Similar to all inflammations, and here we have contiguous spread, in this case involving the testicle with an abscess. Doppler would show increased flow with any kind of inflammation. Typically, the epididymis is not all that vascular. You do see a little bit, but certainly not to this degree. And the testis also, in this case on the right side, has increased flow compared to the opposite side, suggesting accompanying orchitis. Now, what's going on in this case? Is this acute epididymitis with an enlarged tail? Actually not. This is a mimicker, or superficially, you might make an error, but it's a look-alike. What is this? Well, there's hyperemia in this structure, but is this coursing to the head of the epididymis, as I've shown you previously? We don't see the head of the epididymis in the expected location, but now I see it, but that is not associated with the area that I'm showing you back here, which is the same structure as we're looking at here. So what's going on here? Well, let's turn to our diagram and realize that what we're looking at here is actually a prominent ductus deferens or vas deferens. Remember, it's a retrograde infection. And in some people, for some reason, this inflammation is much more prominent than the inflammation in the epididymis. I've also seen people call this a hernia. Always look up by the inguinal canal, and you will realize that there is no hernia at that level accounting for this structure. So don't get fooled. This is inflammation, but don't call it a hernia. Recognize it for what it is. Look carefully.